Hello everyone and welcome to the American Indian and Alaska Native Behavioral Health webinar series. I'm Kate Trams and today we have welcomed Jenny Gringer Richards to present Technology-Based Clinical Supervision. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more about the ATTC network, please visit our website. We are looking forward to having Vanessa Simons present in the series in September on Environmental Health Literacy for Youth. And for our Essential Substance Abuse Skills webinar series, we'll be having Matt Ignacio come back to present on group counseling on August 17. So please join us for both of those upcoming sessions. Our center is a NADEC certified educational provider, and we'd be happy to provide you with CEHs for a $15 fee. The request form is available for download in the files pod in the webinar screen and will also be sent in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GIPR evaluation. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so please use the Q&A pod to share your questions and comments, and we will address questions at appropriate points during the presentation. If you prefer, you may view the presentation in full screen mode by clicking on the full screen button at the top right corner of the pod, which looks like 4 arrows pointing outward. To return to the regular view, click the button again. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, and this may be reflected in the number of CEHs received. The opinions expressed in this presentation are those of the presenter and do not necessarily reflect the official position of CSAT, SAMHSA, or the U.S. Department of Health and Human Services. So today we have our very own Jenny Gringer Richards presenting for us, and she has worked with us at the American Indian and Alaska Native ATTC on evaluation, curriculum development, research formulation, along with writing grants, reports, abstracts, and occasionally running focus groups. She has been collaborating with her coworkers to craft innovative trainings, abstracts, and posters that raise awareness of American Indian and Alaska Native culture, traditions, and spirituality, and how to use that information better to serve that population. So I want to welcome Jenny, and I'll pass things over to her at this time.
Thank you so much, Kate. That was a very wonderful introduction. I want to welcome everybody to the call today. We have a really big presentation that's normally a one-day presentation that has sort of been compressed to a 2-hour presentation that unfortunately I've compressed into about an hour. Now what I want to say as we get going is in the lower left-hand corner, you'll see the handouts for technology-based clinical supervision, and I really encourage you, if you're interested in this topic, to print those out. There's great information in the notes, and it's the full presentation. So today you're getting the super-duper abbreviated version. This presentation was developed by the National Frontier and Rural Addiction Technology Transfer Center, or as we call them, NFAR ATTC, and their purpose is to focus on frontier and rural issues related to addiction treatment and recovery services. And as I've already warned you, due to time constraints, this has been abbreviated and compressed. Here we go. So to begin with, we start with a disclaimer that's going to be repeated several times during the presentation. Neither NFAR nor myself endorse or promote the use of any specific technology application mentioned in this training. All technology applications discussed are examples that are available resources only. NFAR does not guarantee that any technology application discussed is compliant with HIPAA, HITECH, or any other federal, state, or local confidentiality regulation. And we encourage everyone, before you adopt any technology, to consult with an attorney, your institution's HIPAA compliance officer, and or your local licensing agency before utilizing or purchasing any technology for clinical supervision purposes. So there I said it. The big picture. As I said, we've compressed this a lot, and so there's 2 main points I really want to get to before, to set the context before we get into the how this all works. First of all, we understand that substance abuse disorders are widespread and occurring at a higher rate in rural areas with more limited access to services. Secondly, health disparities are closely linked with social, economic, and environmentally disadvantaged populations. According to, oops, According to a 2011 national survey on drug use and health, more than 20.6 million people aged 12 and over met the criteria for substance use disorders. 95% or 19.2 million did not feel they needed treatment, and 3% felt they needed treatment but did not make an effort to get it. Reasons for not making it an effort to receive treatment include, and I'm sure you all are very well aware of this, the stigma that still exists regarding addiction treatment, lack of access to treatment, which is incredibly important in rural areas, and the cost and hassles related to attending treatment. So there it is in a nutshell. One of the problems we face in disparities in treatment needs, we want to move on. We also want to talk about issues with the substance abuse workforce and current access to clinical supervision, which is sort of the second problem. The current workforce really is facing three main problems: turnover, aging, and recruitment of new counselors. The turnover rates in rural settings have reached alarming rates, sometimes over 20% per a 2008 study. And this poses a threat to the quality of care that clients receive by disrupting the client-therapist relationship. It's costly, time-consuming to rehire and train new counselors periodically. Efforts to replace clinical staff may also undermine organizational efforts to adopt and implement evidence-based treatment practices. And also, with high turnover rates and a limited workforce, agencies may retain ineffective employees because of challenges related to replacing them. In terms of aging, in a 2012 workforce study conducted by the ATTC network, it was revealed that 60% of clinical directors were over the age of 50, and the average age being 52 years. Although younger than clinical directors, 49% of direct care staff were over the age of 45. So with few young people coming into the substance use treatment field, the workforce continues to experience shortages that will get very severe in the not too distant future. Also, in terms of recruiting new counselors, low pay, stigma associated with the field, and lack of qualified applicants all present recruiting challenges. Low morale comes from working, as you all know, in an understaffed environment with low pay and low professional support. So, again, abbreviated, I know. So in terms of one solution we propose is finding a way to provide quality clinical supervision. And I want to talk about why this is so important in increasing the quality of care and workforce stability. So to begin with, what is clinical supervision? And here's a thing I'll probably stumble over as I read it. The relationship is evaluative and hierarchical, extends over time, and has the simultaneous purposes of enhancing the professional functioning of the junior person, monitoring the quality of professional services offered to clients, and serving as a gatekeeper for the particular profession the supervisee seeks to enter. The three key elements of clinical supervision include enhancing the professional skills of the supervisee, monitoring the quality of counseling services, and serving as a gatekeeper for the profession. A little more about that. The role of the clinical supervisor is to transmit the field's values, body of knowledge, professional roles, and skills to the new clinician. Training and supervision are also primary vehicles through which the field evolves. They prepare the future generation of workers to be representatives and developers of the field's viewpoint, with the hope that they will move beyond their mentors' conceptual, therapeutic, and professional development. So quality clinical supervision, per our workforce survey in 2012, found that 92% of clinical directors identified direct supervision as the most common strategy for developing skills and enhancing treatment outcomes. Clinical supervisors can serve as an opportunity to identify areas of need that need improvement and provide skills Training. Regular supervision can result in better counselor skills, improved treatment outcomes, higher staff satisfaction and morale, and counselors who stay in their position longer, which is really what the field needs. As a supervisor that provides oversight to many different offices in rural areas, it is impossible to be everywhere you are needed all the time in person. Some of our providers are in extremely remote areas, and perhaps one man, one woman shows. This contributes to isolation and the inability to use a team approach for clinical staffing. In addition, when experiencing problems with consumers, there are few resources to reach out to and gain perspective or insight in how to handle that situation. As a supervisor, it's difficult to feel like you're really connected to the staff person, which results in supervision meetings not occurring frequently enough, because to get them in person would mean you as a supervisor have to mark out a whole day to provide the meeting time, because travel might take up half of it. So those are the realities on the ground. Now we want to talk about technology as being part of the solution here. So technology-based clinical supervision can be as low-tech as a telephone or email, or as high-tech as utilizing technology as a way to provide face-to-face supervision, sort of through live feeds, combinations of the above, web chats. Many people, of course, you might be included, though maybe not, because you're on a webinar and I see you're all logged in through the computer. Technology doesn't have to be a barrier. Low-tech options are often effective. Again, we're talking telephones here, people. And two, technology is improving the ease of use. It's getting easier and more user-friendly all the time. Clinical supervision delivered via telehealth technologies has a lot of benefits. But given the interpersonal nature of supervision, one might wonder if the trade-off is diminishing supervision quality. The excellent news is that multiple studies show there is no loss of quality when delivering supervision through technology. So that's good. So here's a slide, and we're going to go into more detail about this later, about what NFAR feels are the benefits to utilizing technology-based clinical supervision. So I'm going to kind of jump in. Number one, it increases the access to quality supervision. So this provides a way to provide workforce development without the burden of expensive and time-consuming travel, particularly to rural providers. This is allowing a more nimble approach to supervision, where a clinician may be able to access supervisors with a specific population expertise. For example, adolescents, homeless youth, military veterans, where the provider may not have those expertises but can consult with somebody else. Also with specific therapeutic techniques or expertise to maximize specific skills with specific populations. Next being enhancing cultural competency. Now this was not extremely evident to me when I first looked at it, but if an on-site supervisor doesn't have culturally relevant experience, it might be possible to utilize technology to access a consultant who does have relative experience or insight. It's also a 2002 study looking at a triad model of supervision in which supervisees have two supervisors, one on site who may be well versed in the local culture, and one online who may possess, needed competence in evidence-based practices. Benefit number three is that it's going to strengthen the professional identity of the supervisee. So one of the ways in which clinical supervision leads to better client outcomes is being observed, and receiving support and feedback helps people to strive and improve their work and develop new and better skills. And this is really the driving force between competence and mastery. It also develops professional support mechanisms, which will ultimately help with ongoing retention of healthcare professionals, and the support they can expect to receive once they have elected to begin that kind of a rural practice. Connecting with peers and maintaining educational credentials become an important part of the overall professional identity and career satisfaction. Benefit number 4 supports program integration. Um, Macro level changes in healthcare will hasten the integration of substance use disorder treatment professionals in healthcare settings. As the number of clinical settings in which substance use disorder treatment providers are working in increases, the need for accessible supervision also increases. So in terms of models of integration, video conferencing is increasingly being used also, and this may be surprising, by urban clinicians who seek training in particular specializations from geographically different experts. Another quality care issue that technology-based supervision may address is the fragmentation of care and the need for continuity from inpatient to outpatient care, transfer to local primary care providers, termination of services, or self-help maintenance or care. It also may address barriers related to health disparities from rural residents by bringing experts into the system. Integrated care is one approach to addressing unmet needs. In contrast to referral models, integrated care involves a systemic linkage of mental health and primary care providers that requires close communication and coordination between providers to meet both mental and general health needs of the patient. Okay. So benefit number 5, it's shepherding in a new era of technology. Not only are healthcare settings becoming more integrated in terms of types of healthcare professionals working in one setting, but they're also increasingly relying on technology to meet the needs of patients. Technology-based clinical supervision increases comfort with technology, which is important to service as service delivery itself becomes more and more infused with technology. And lastly, number 6, it's promoting fidelity to evidence-based practices. Ongoing supervision following training in evidence practice leads to better skill retention and higher adherence to intervention. It's not enough for counselors, and this has been the model for years, to go to trainings on evidence-based practices. You go to a conference, you come out, you've got it, it's done. Well, we know it doesn't really work like that. People need ongoing interactive support. So here's a quote from Smith, 2012. The dissemination of new evidence-based treatment methods into widespread clinical practice is a substantive change for addiction treatment field. Continuing education programs have traditionally used printed material and didactic conferences for disseminating treatment advances. However, evidence suggests that these traditional approaches to training are relatively ineffective at changing actually counseling practice. Training procedures that include interactive role plays relevant to clinical context allow opportunities for further practice, feedback, and reminders that are more likely to enhance clinical skills. One thing we do a lot, and where I work, is following a conference where we have a training is we do 6 months of learning collaboratives where people have the opportunity to get together either online through a webinar or via phone, where you can talk about it and ask questions in terms of implementing changes into their treatment. And those seem to be incredibly effective in actually creating change. So overall, the use of technology-based clinical supervision can improve client outcomes. The 2 main reasons for clinical supervision are to ensure quality care is provided to the client, and 2, that clinical staff are receiving the professional development they really need. These in turn lead, of course, to better client outcomes. So in terms of what the goal is here, is to ultimately reduce the isolation of healthcare providers in rural communities, increase access to clinical consultative services and health education programs for rural supervisees, to provide supervision and expertise that would not otherwise be available in rural settings, and to provide feasible, sustainable system of supervision consultation. So what do I mean when I'm talking about technology-based clinical supervision? As you can see, you may all be familiar with the telephone. This is not new technology, but it's very basic HIPAA-approved technology. There's telephone, video conferencing, digital video and audio recordings. I mean, really, we're not talking high tech here. Email, text, chat, instant messaging, and to the higher levels of apps that you can use on your smartphones or tablets, avatars. So there's a lot of different ways to go with this, from high tech to really low tech. Regardless, whatever you're doing, it's important to remember to never discuss protected health information unless the technology is absolutely secure, password protected, or vetted by a legal expert. So we know telephones are okay. To be aware of the tone and style, check in and make sure your meaning is understood. We know with emails this can be a humongous problem. Develop a communication structure that includes systematic check-ins and summarization. And also, remember, engagement is the key to success. So you want to utilize these kind of technologies to pull people in, to make everyone feel comfortable. Using the technology will help it allow it for more meaningful supervision. So this means special care must be taken to select the best types of technology for your team, something everybody's feeling comfortable with or can feel comfortable with in fairly short order. So let's see. To begin with, again, our old friend, the telephone. I know, this is cute. A telephone, can be used for direct observation. You can set up a conference line, and a supervisor can listen to a live session over the phone, or for supervisory feedback for individuals or group at any time. It's also the best option for use in times of crisis, of course, and for discussion of matters that may include that protected information we've talked about, and when a secure online discussion is not an option. So when it's needed is, you need a phone with a good connection. Certainly with cell phones, we don't always have great connections, and landlines are a blessing like that. You need a good microphone. A headset might be useful for the supervisor listening to a live session. I mean, the benefits, of course, of the telephone are it's HIPAA compliant, user-friendly, inexpensive, widely available. Everybody has one. Versatile in the way it can be used with clinical supervision, and permits participants from multiple locations to participate synchronously. All together. Sorry. Video conferencing. So, of all the new technologies being applied to supervision and training, video conferencing is quickly becoming one of the most widely used mediums in practice. A video web conference, and there are many ways to set this up. You can use things like GoToMeeting, Zoom, Adobe Connect, Skype, or Google, can be used directly with the counselor to provide feedback on the session and go over what went well. It provides you a visual of how things are going as well, so you can read body language and things like that. You need computers or devices like tablets or smartphones for everyone, devices with built-in cameras that need, or with add-on webcams. Good, solid internet connection is essential here. Plug-in headphones are helpful to reduce feedback noise from the computer's microphone for the people observing. Some of the benefits, again, like I said, are audio and visual cues can be observed. Interaction can be in real time. There are free options which make it cheaper than a phone. It permits participants from multiple locations, and it can be accessed by smartphones, tablets, computers, sometimes even TV. It also, being able to see people produces a meaningful sense of alliance among participants. This is not exactly the same, but it's quite equivalent to in-person supervision. Both trainee and supervisors reported preparing more thoroughly for video conference supervision, perhaps because of the uncertainty about this new format. Research is also suggesting that video conference supervision has the potential to increase self-disclosure and reduce inhibition in supervisees. Video conferencing can be effective internationally or in cross-cultural supervision. Okay. So here's another old school one. Digital video or audio recordings. Now, this has been done for a very long time, and you may have done this as well. This training um, discusses shared digital videos or audio recordings, and also creating and sharing recordings of therapeutic sessions as a means of observing supervisees may be also the most risky regarding HIPAA privacy and security and federal confidentiality rules and regulations, even though it's been done for a very long time. So for supervisors who want to recordings of supervisee sessions, multiple options exist. Client counselor sessions can be recorded via digital audio, video, or audio recording. Counselors can share the recording with their supervisee for supervisor reviews video and provides feedback to the counselor. Can do it via phone, email, web conference, any other means of communication. So here's where there can be that distance. The video can be dissected and replayed for discussion during group supervision or via web conference. During a group supervisory session, the supervisor might share the video or audio of his or her own session with a client to demonstrate the use of evidence-based practices, and the group can discuss the techniques and challenges of those techniques together. The supervisor and supervisee might also choose to watch and listen simultaneously, and the supervisor may use the telephone or text chat window or electronic whiteboard to comment on the recording live while it's playing. So, I mean, this is a great educational tool. The benefits are it can capture counselor-client sessions. It is inexpensive. It's malleable, and how you want to use it. There's many different ways. It also produces a record of the session that can be easily shared and can be used to track counselor skills development in progress. Email. So with email, we've talked about email a lot lately in the news. Email is great to use to provide feedback or answer questions. One small study in 2002 showed that emails between supervisors and supervisees tend to fall into three main categories: praise and reassurance, challenge and confrontation, or advice and direction. Offering praise and reassurance in particular plays an important role in building confidence, which is critical to helping supervisees establish their professional identity and responsibility for their actions. Providing this feedback in writing can also help promote reflection and allow a recipient to revisit the remark later or think about it a while, come back. The benefits of email, of course, it's easy to use, it supports flexible timing of interaction, provides ongoing access to clinical supervision, promotes a more relaxed communication style. It increases time to process and clarify thoughts as sort of complex matters come out. It's greater monitoring capacity and record keeping. It decreases inhibitions. People feel, for whatever reason, more comfortable sharing things via email. For supervisors, writing in an email can help clarify their own thoughts and experiences and provide them with better insight into the challenges rather than just saying something. Like, it gives them time to sort of think it through and respond. So it supports continuous self-reflection. In terms of security with email, again, I'm just going to read the slides here. Emails are stored at multiple locations, as you're well aware. Your internet service provider and the recipient's computer. Deleting an email from your inbox doesn't mean there aren't multiple copies still out there. Emails are vastly easier for employers and law enforcement to access than phone records. And finally, due to their digital nature, they can be stored for a very long period of time. So again, with email, it's really important to try your best to not reveal protected identifying information. Text, chat, and instant messaging. Quick conversations can occur between one or many people and can be used to provide prompts during live client or counselor sessions. So this gets into the more high-tech approach, which I'm afraid we don't have a lot of time to talk about, but some of these programs allow for somebody to be observing live and then The provider themselves can be holding a laptop or a tablet, and the provider can be giving live feedback. They can also do this through an audio device. So helping somebody really bring in these skills with live assistance that's also remote, so they're not in the room. Um, so benefits allows for supervisory feedback in these sort of live direct observation sessions without alerting the client to the supervisor's presence, which can, as you may know from experience, can be disrupting to that client counselor interaction and building of relationship. It happens immediately. It can and there you have the ability to find secure applications, which unfortunately are not listed in my materials. But maybe if we dig a little more, we can find some. And it's easy to use. It's something, texting is something people are getting more and more familiar with and comfortable with. So there's also apps for smartphones and tablets that you can use for chat and video conferencing to provide rapid feedback during the live session. So sort of what I was alluding to. This is accessible on many devices. It's portable. It is the cutting edge technology, which brings you into an area where it's less explored through licensing boards, HIPAA, and high tech. So it's important before you utilize any of these things that you're checking with, your HIPAA consultant, your attorneys before you utilize these things. But it's a way to, and this is the future of bringing all the technologies discussed into a smartphone or tablet, which has excellent portability, particularly for people who do treatment in homes, and is more developed to respond to the specific needs of clinical supervisors and clinicians. So, what do you not use? Facebook. Everybody uses Facebook. Don't use it with your clients. Really bad idea. Public Wi-Fi to access confidential files, incredibly bad idea. Don't do it. Email, chat, or text message to exchange protected health information unless it's through a secure, super password protected program. But as a general rule, just don't do it. Advice from other people about using don't use other things without consulting your HIPAA compliance resource expert, attorney, or licensing board. And don't use any technology without the client's consent. And it's easy to talk to a client and say, I'm at this point where I'm getting feedback from a supervisor to help me improve my care. Are you okay with this? So they have to consent to anything you're doing. Okay. So on to an abbreviated discussion of the ethical issues, which are many and complicated. Um, te Technology will continue to evolve, but ethical principles will remain constant. It's important for clinical supervisors to consider the role that technology plays in vicarious liability, dual relationships and boundary crossing, informed consent, and confidentiality. Research ethical standards for technology-based clinical supervision. Professional boards are establishing more and more ethical guidelines specific to technology-based clinical supervision. I mean, they're moving ahead with the technology as well. Clinical supervisors are responsible for determining which guidelines apply to their work, and when in doubt, apply existing face-to-face supervisory standards to any work done via technology. So, and we've hit on this a bit, it feels like, but it's important again before implementing any technology to check with your state certification and licensing boards to see what issues you may need to consider and be aware of. In a 2010 study, 60% of boards limited the hours of internet-based clinical supervision that could be applied to licensure, with the limits ranging from 10 to 50% of total hours. State or licensing boards, laws, and regulations may prevent supervisors from providing supervision to someone in another state. Reciprocity of licensure is based on participating states or provinces confirming their license requirements to accept each other's licenses. Reciprocity is a possible solution to the issue of portability. However, only a few states at this time have regulations for reciprocity currently in place, and this was in 2010. So I bet it's come a long way since then. Supervisees using video conference for distance supervision or training are advised to form good relationships with local mentors and consultants in case clinical issues arise that may not be well addressed by distance supervision, such as compliance with local laws, regulations, and professional guidelines. License portability is an issue to ensure access to quality care in rural issues. This is important to place to consider your role as an advocate for clients. Oops. Okay, so in terms of privacy, security, and confidentiality. Again, broken record, we do not use names or identifying information in technology as a safeguard. Delete electronic messages, emails, postings on the internet periodically to cover yourself. Develop security protocols and passwords for access to group supervision information. Use encryption whenever information is sent from one computer to another, and discuss sensitive information offline. This is so important. Don't forget to use, offline technologies when you need to speak about sensitive issues. Supervisees must understand when it is appropriate to use the telephone and not rely on a computer. So, in terms of enhancing your online security, use strong passwords. So not your pet, not your birthday, not your names or dictionary words. One really cool advice I've heard recently is to write a sentence. This is wonderful. It's easier to remember and it's long. Use a unique password on each account, and we all go crazy doing this, but it's really important to protect the security. Use two-factor identification on all accounts. Use extreme caution when downloading attachments or clicking on links in emails. I think we've all done this before. And lastly, be sure you're using the most updated antivirus and anti-spyware software. Okay, so privacy rules overview. HIPAA, the health, bump ahead of me. Okay, HIPAA, the Health Insurance Portability and Accountability Act. Video conferencing, texting, document sharing, and email usually involves the transmission of patient-protected health information, and thus may fall under the regulations of HIPAA if personal health information is exchanged. In order to be HIPAA compliant, there needs to be a business associate agreement with the technology company, protocols to limit and track to access to protect health information. If asked, the technology companies need to produce logbooks of who has access to the personal health information and why. If there is a breach in security and any of this personal health information is leaked, these companies are supposed to notify the covered entities, i.e. the counselors. For more information, let's see. If you're going to go, okay. For more information, if you go to this slide in your handouts, it's the onlinetherapyinstitute.com, and it's under video conferencing, secure, and HIPAA compliant information. With regard to high tech, the Health Information Technology for Economic and Clinical Health Act, they've expanded the definition to include an IP addresses and even zip codes in more rural areas. Skype and similar consumer-level companies often keep records of information that qualifies as protected health information, such as IP addresses of the therapist and client involved in the call, but do not provide necessary assurances that these pieces of information will be protected. Skype and other common video conferencing platforms, such as Google Hangouts, may be used for conversations between supervisors and supervisees, but they are not appropriate for transmission of protected health information. If video conferencing is to be used for sharing videos of client sessions and discussing client information and live supervision, a fully vetted HIPAA-compliant platform must be used. There is video conferencing software that permits compliance with HIPAA and high tech that is available at affordable pricing. And here are the names: OmniJoin. So again, in the notes on the slide and the handouts, OmniJoin, WeCounsel.com, GoToMeeting, Via3, MegaMeeting.com, Console, COUNSOL.com, SecureVideoConference.com, VC.com, and VirtualTherapyConnect.com. So there's a lot of resources in these notes that are really going to be good for you to look at. And if you have questions at the end, I'm also going to give you my email and the NFAR website so we can help you a little bit. But again, we don't recommend or support or necessarily even have experience with these things. So there's that. But we just wanted to lay out some for you to investigate. Okay, again, I stress this never highly enough. Before you begin delivering services and purchasing equipment, please, we urge you to seek legal advice. We said this at the beginning, and I say this toward the end. There's no guarantee that any of the platforms or technologies discussed are compliant with federal or state confidentiality rules. Supervisors must seek advice from legal counsel, licensing boards before using technology to electronically transmit protected health information. Okay, here's the shocker. Do not, I repeat, do not ever utilize YouTube as a way to have a digital recording of clinical supervision. It's not secure in any way. So in conclusion, technology-based clinical supervision can open the door for expanded and improved services by clinicians who have limited access to supervision. I mean, we understand the support of providers in the field is of utmost importance for morale, for improving their skill level and feeling good about the work they're doing. This is a key area of support that needs to happen on a regular basis. And I'm done very early. So if you have questions, please type them in the Q&A box. And then I also refer to NFAR, who are the experts who wrote this presentation. But if you think of a question later, feel free to contact me at any point in time. I would love to hear from you. And thank you so much for your time today.
Thank you so much, Jenny. That was a wonderful presentation. I hope everyone got a lot out of it. And just take a few moments. If you have any questions for Jenny, we'd love to take some right now. Just type those into the Q&A pod, which is just to the right of the presentation. Your cursor goes in at the very bottom, and you type in right there. So I will just take a moment while we're waiting to see if any questions come in to remind everyone. When we close out today, we'll be directed to the GIPRA evaluation. We really appreciate your feedback. So please, if you don't mind, take a few minutes and just fill out that quick survey. And then also, we will be sending a follow-up email. You'll get a link to the recording of this webinar, as well as the handouts and a CEU request form in case you weren't able to download one. And if you want to pass this on, the recording, feel free to share that link with anyone that might be interested in it. And just so you know, too, for future webinars, we also send that link out to anyone who registered. So if there's a webinar we're doing coming up that you aren't able to attend live, you can always just register and you'll receive the link to the recording after the event. So it looks like we don't have any questions right now, but like Jenny said, please feel free to get in touch with us after the fact if anything comes up that you didn't think of. So we do actually have, just a comment from Anna. Thanks so much for the comment. Yeah, she said it is a challenge to implement much needed change, and that's something we can definitely identify with. So thanks for sharing that thought. Jenny, do you have anything final you want to say before we close out?
I would like to say to Anna, if you go to the nfarattc.org website, I believe you can access this presentation in its longer form. It's about 99 slides. I cut it down to about 56 here, but it is really good information. It's better to take it in slowly. Again, this was designed to be an all-day, one-day training, which was really good when I saw it the first time. So I do recommend contacting NFAR if you have questions about that, and really looking up and trying to share this information. I think it's really pertinent right now. So thank you for that.
Oh, and I wanted to mention too, Jenny said the slides that NFAR has on their site is a longer version, and that is actually the version that we used for the handouts. So the handouts include all 99 slides. And so there are some you'll see in there that we did not go over today. But as she mentioned, this is normally done as a full day training. So yeah, if you want to go more in depth in this topic, NFAR does offer this training, so you can look for that on their website as well. So with that, I believe we're all done. Thanks again for joining us, and yeah, we hope you have a great day.